anti-emetic drugs or drugs used for vomiting. The drugs used for vomiting are called anti-emetic drugs. Now, anti-emetic drugs we have already covered in many parts of the pharmacology. So we will club them together to make this topic. We discussed anticholinergic drugs like hyoscine. It is used for motion sickness. Prophylaxis of motion sickness, we use hyoscine. Then antihistaminic drugs, particularly first generation antihistaminic drugs, they can also be used in motion sickness. Now, one of the first generation antihistaminic drug, which is called as doxylamine, it is a drug of choice for morning sickness, vomiting of early pregnancy, morning sickness. Drug of choice is doxylamine. Then we have 5-HT3 blockers. You know 5-HT3 is present in CTZ, it causes vomiting. The drug blocking 5-HT3, the drugs whose name end with cetron, like ondansetron, granisetron, tropisetron, palonosetron. These are used as anti-emetic and they are drug of choice for three types of vomitings. One, they are drug of choice for chemotherapy induced vomiting. Second, they are drug of choice for radiotherapy induced vomiting. And third, they are drug of choice for post-operative vomiting. 5-HT3 blockers are drug of choice for chemotherapy, radiotherapy and post-operative induced vomiting. Out of the 5-HT3 blockers, palonosetron is most potent 5-HT3 blocker. Most potent 5-HT3 blocker is palonosetron. Then we have a new group of anti-emetic drugs which are called as neurokinin antagonists. Neurokinin antagonists. And most important neurokinin we have is substance P. So simply they are also called substance P antagonists. The drug which is present is aprepitant. The new drugs in this group are Nupitant and Rolapitant. From the name you can remember their mechanism. They are P means substance P, ant means antagonist. They are substance P antagonist. The drugs ending with pitant belong to this group. Now these are the drugs which are drug of choice for delayed vomiting due to cisplatin. We know cisplatin is most emetogenic anti-cancer drug. Most of the patients who are given cisplatin develop immediate vomiting. That means within 24 hours vomiting develops. But few people, they do not develop vomiting immediately but after 24 hours, which is called delayed vomiting. Drug of choice for early vomiting due to cisplatin or most of the other anti-cancer drugs is 5-HT3 antagonists like ondansetron. But delayed vomiting do not respond to ondansetron. So the drug of choice for delayed vomiting due to cisplatin are substance P antagonists like aprepitant. Then the last group of anti-emetic drugs are dopamine D2 antagonists. We know dopamine causes vomiting. If we block dopamine receptors, we can treat vomiting. And we have two important drugs. One is metoclopramide and second is domperidone. Metoclopramide and domperidone are D2 antagonists. The important difference between these two, both are acting by blockage of D2 receptors. but metoclopramide can cross blood-brain barrier, whereas domperidone cannot cross. Second difference, metoclopramide has additional mechanisms to produce anti-emetic effect, particularly it has 5-HT3 receptor blocking property, as well as it can stimulate 5-HT4 receptors, whereas domperidone has no other action, only D2 receptor blockade. So because of these differences, metoclopramide has more actions, so it is more effective anti-emetic drug as compared to domperidone. But because metoclopramide enters the brain, so it can block D2 receptor in the brain also. And if you remember, excessive blockade of D2 receptors in the brain can lead to extrapyramidal side effects. So metoclopramide can cause dystonias, extrapyramidal side effects. Domperidone will not cause this side effect. On the other hand, if a person is developing vomiting due to levodopa, remember levodopa used in Parkinsonism? Levodopa will form dopamine, and that dopamine will stimulate D2 receptors to cause vomiting. So if we want to treat levodopa induced vomiting, we will like to block D2 receptors, and we have metoclopramide and domperidone. So which drug will you prefer? Yes, we will prefer domperidone. Why domperidone? Because domperidone will block the vomiting and it do not enter the brain, whereas metoclopramide will enter the brain, and by blocking the D2 receptors in the brain, it will aggravate or worsen the Parkinsonism. So that means metoclopramide will not only stop vomiting but also the therapeutic uses of levodopa. On the other hand, domperidone will treat vomiting without interfering with efficacy of levodopa. So domperidone is drug of choice for levodopa induced vomiting. So these are the important points regarding the anti-emetic drugs. The next topic in the GIT are drugs for diarrhea. Now we all know diarrhea can lead to dehydration. The most important thing in diarrhea is to prevent dehydration, and that we can prevent by giving ORS, oral rehydration salt. So ORS is the most important thing in diarrhea. Most of the diarrheas are self-limiting. So by giving ORS, we will prevent the dehydration. ORS consists of sodium chloride, potassium chloride, trisodium citrate, and glucose. Sodium, potassium and chloride, these are the electrolytes which are lost in the urine. So we are giving them to replace the electrolytes. Trisodium citrate is used to prevent the acidosis. It will alkalinize the medium, so acidosis will not occur. And glucose, the most important use is of glucose. In the intestine, there is presence of sodium glucose transporter. And this transporter keep on working even in extreme diarrhea. All other transporters may stop, but this transporter keep on working. So glucose is given so that sodium can be absorbed. In severe diarrheas, transport of sodium may stop, but sodium facilitated glucose transporter, so sodium glucose transporter keep on working, so that will help in absorption of sodium. So ORS is most important in diarrheas. Now apart from ORS, if the diarrhea is due to infection, then we can give antimicrobials. So two major antimicrobials we use for diarrhea. One is metronidazole group of drug, and second is fluoroquinolones like ciprofloxacin. So if it is amoebic diarrhea, we will give metronidazole. If it is bacterial diarrhea, we will give ciprofloxacin. But remember, person usually develop only one infection, not both of them together. So a combination of metronidazole and ciprofloxacin is irrational because we are always wasting one drug. We are adding to the cost and wasting one drug, so combination should not be given. Only one of the two drugs should be given. Then for non-infective diarrhea, we can use drugs which decrease the motility of GIT. The drugs like loperamide, diphenolxylate, they are used for non-infective diarrhea. They will decrease GI motility and that will treat the diarrhea. If diarrhea is due to secretions like VIPoma or carcinoid syndrome, then we can use another drug which is somatostatin. Remember, somatostatin inhibit the secretions in the GIT, and the drug which is somatostatin derivative is octreotide. So we can use octreotide for secretory diarrhea. Lastly, recently we have found a new drug which is called as resicadotril. This is a drug which acts by inhibiting an enzyme called enciphalinase. In the body, there is presence of enkephalins, and these are metabolized by an enzyme called as enkephalinase. Resicadotril inhibit this enzyme, enkephalinase. Now, what are enkephalins? Enkephalins are one of the endogenous opioids. So we have endorphins, dynorphins and enkephalins, which are endogenous opioids. And we know opioid will help in treating the diarrhea. Remember the mnemonic we discussed in opioids, saccharum. So they cause constipation, means they decrease diarrhea. So if we increase the endogenous opioids, we can treat diarrhea. So resicadotril inhibit enkephalinase. So there is increase in enkephalins, so that is used for treatment of diarrhea. So these are the important points regarding the anti-diarrheal drugs. Now the last topic in the GIT is inflammatory bowel disease. We have two types of diseases in this category. One is Crohn's disease and second is ulcerative colitis. And the basic difference between the two is written in the name itself. Ulcerative colitis mainly affect colon, whereas Crohn's disease is a diffuse disease throughout the GIT. In both the cases, there is inflammation. The drug of choice for ulcerative colitis is 5-amino-salicylic acid. The problem is, if we give only 5-amino-salicylic acid, it will be absorbed from the stomach itself. So very less drug will be able to reach the intestine or colon. So we want that it should not be absorbed in the stomach, it should go till the colon. So we want to prevent the absorption in the stomach. So that we can do by combining this with some other substances. So which substance we can combine with 5-ASA? First of all, we can combine this in a drug called sulfasalazine. This is a combination of 5-amino-salicylic acid with sulfapyridine. So sulfapyridine prevent the absorption in the stomach. In the intestine, the azo bond between the two breaks, 5-ASA is released, so it can treat inflammation of the colon. The same thing we can do in olsalazine. Olsalazine is a compound in which there is a azo bond between two 5-amino-salicylic acid molecules. So this is not absorbed in the stomach. The azo bond is broken in the intestine and it can produce the effect there. Then recently we have developed some pH sensitive tablets of 5-amino-salicylic acid. These are called mesalamine. These help in preventing the absorption in the stomach and it can work in intestine. So 5 amino salicylic acid derivatives, they are drug of choice for ulcerative colitis. If these preparations are not able to treat the inflammation, then the drug of choice are corticosteroids. On the other hand, Crohn's disease is a diffuse disease. So we not only want action in colon but all over the GIT. So the drug of choice for Crohn's disease are directly corticosteroids. If corticosteroids are not effective, then we will give TNF alpha blockers for Crohn's disease. TNF alpha blockers are used, and the drugs which are TNF alpha blockers used in Crohn's disease like adalimumab, certolizumab, etanercept, infliximab. So any of these can be utilized in Crohn's disease. They are TNF alpha blockers indicated in steroid resistant Crohn's disease. So these are the important points regarding the drugs used in GIT.